welcome everyone. Let me begin with a little background around IMO. IMO has been the primary driver behind clinical interface terminology. We began in 1994 when few clinicians were even using electronic health records. Today we are the premier supplier of clinical interface terminology to the US and English-speaking markets, with more than 70% of acute care facilities, 4,500 hospitals, and over 500,000 daily clinician users in the US alone. We complete your clinical terminology foundation needs. So any disruption in the revenue cycle is highly impactful. Preventing the use of outdated or wrong codes is key, and preparing your organization for the new ICD-10-CM codes effective October 1st supports an uninterrupted revenue cycle. And we will start. Here are our objectives for today's session. And we're going to start with a couple of impactful acute inpatient prospective payment system rule changes, and then review specific code changes. So let's get started on our objectives. Prior rules and requirements for new ICD codes to be implemented on April 1st were for new diagnoses or new technology. A couple recent examples of these were vaping and COVID-19. The topic of considering an April 1st implementation date for code updates was raised at the March 2021 ICD-10-CM PCS Coordination and Maintenance Committee meeting and proposed in the acute IPPS rule. The proposed inpatient prospective payment system rule outlined the rationale for the change. The additional implementation date allows for earlier recognition of diagnoses and conditions in addition to procedures and treatments in the claims data. Earlier recognition is beneficial for data collection, tracking clinical outcomes, claims processing, surveillance, research, policy decisions, and data interoperability. The proposal expands the eligibility beyond current criteria to create a semi-annual update. And on the next slide, we will review more details related to this change. Regarding timeframes, in November, the changes for April 1st codes will be announced publicly. The announcement includes designations such as complication comorbid, major complication comorbid conditions, in addition to the code and code description. The files would be available in February. The final IPPS rule noted the public comments of the need to balance the burden of updates with the need for new codes. While additional details were provided at the CNM meeting, the rule notes a phased approach at the start to balance the move to a semi-annual update process. So initially, the number of new codes may be fewer. The final rule noted a potential example, such as requests for new codes that have been through various rounds of the Coordination and Maintenance Committee meetings could be planned for an April 1st implementation. The resource section contains additional web links for further details regarding April 1st implementation date. Let's review another change from the IPPS rule related to laterality. The proposed rule raised the issue of capturing additional specificity included in ICD-10-CM, specifically related to laterality codes. The potential impacted codes identified in the proposed rule are subcategory codes designated as CC/MCC and have an unspecified code within the same subcategory where other codes are available to identify anatomical site. So for example, subcategory for fracture of rib has 3 codes, one for left, one for right, and an unspecified side. The proposed rule sought feedback on 2 potential changes: changing the severity level designations for all unspecified ICD-10-CM codes to a non-CC status, where there are other codes available in that subcategory that further specify the anatomical site, as well as creating a new Medicare code edit to signal a more specific laterality code is available. Specifically, this MCE code edit could trigger when an unspecified diagnosis code meeting the earlier stated criteria is entered. The edit could signal to the provider that a more specific code is available to report, The rule noted this edit aligns with documentation improvement efforts and leverages the specificity within ICD-10-CM. The proposed codes subject to the edit are listed in Table 6P.3a and available on CMS's website. The final rule maintains the severity level designations of CC/MCC for those codes. Instead, CMS finalized the unspecified code edit option, as the final rule states, which we believe provides additional time to educate providers while not affecting the payment the provider is eligible to receive. The next slide shows the specific Medicare code edit. The provider must enter one of the two languages shown here on the screen into the remarks section. If there is no language entered into the remarks section as to the availability of additional information to specify laterality, and the provider submits the claim for processing, the claim would then be returned to the provider. And let's look at a few examples of the codes subject to this edit. Here you can see skin ulcers, embolism, thrombosis, and injuries are just a few examples of codes that would be subject to this edit. And again, please refer to Table 6P3A for a full list of codes. And remember, there are coding guidelines for capturing laterality. This slide reflects the laterality coding guidelines, and I wanted to highlight the medical record documentation from other clinicians is appropriate for laterality code capture as stated in this guideline. There are also coding guidelines for the use of unspecified codes. And you can see on the screen, here is the guideline, and the guideline also added content to emphasize the importance of complete and accurate documentation. And now let's turn our attention to the specific code changes by starting with the numbers. ICD-10-CM continues to grow, and for fiscal year, here are the numbers: additions of 159 codes with deletions of 32 and revisions to 20 codes. So what are some of the specific changes? Formerly known as human granulocytic echrolosis, human anaplasmosis is a tick-borne disease with a primary mode of transmission being infected tick bite. Human anaplasmosis infection results in fever, chills, headaches, myalgia, nausea, vomiting, diarrhea, and potential complications such as thrombocytopenia, respiratory failure, anemia, organ failure, and even death. Signs and symptoms usually occur 1 to 2 weeks after the bite. A new guideline was added related to infectious diseases outlined here. You can see for the change is for HIV conditions, and the guideline addresses those patients managed on antiretroviral medications. Two codes, B20 and Z79.899, should be assigned for the situation. Turning our attention to the neoplasms, a bilateral option was added for malignant neoplasm of ovaries as shown on the slide. In addition, the American Society of Plastic Surgeons, ASPS, submitted a request for the condition commonly called breast implant-associated anaplastic large cell lymphoma, or BIA-ALCL. BIA-ALCL is not manifested in the lymph nodes or breast tissue, but is found in the capsule surrounding the breast implant. This is a distinct pathologic disease from systemic anaplastic large cell lymphoma. It is considered an emerging disease by the World Health Organization, National Comprehensive Cancer Network, and National Cancer Institute. This code is listed separately within the subcategory C84.7. When a case is documented with BIA-ALCL, code both the disease and an additional code regarding the implant status. Do not assign a complication code from Chapter 19. Next, looking at our blood disorders, subcategory D55.2 was expanded to include codes for anemia due to pyruvate kinase deficiency, an additional code to capture anemia due to other disorders of glycolytic enzymes. Red blood cell pyruvate kinase deficiency is a rare congenital hemolytic anemia. The clinical course ranges from fully compensated or mildly symptomatic anemia to significant anemia requiring regular transfusions. Newborn symptoms may first appear in utero, such as growth retardation or prematurity. After birth, neonatal jaundice and significant hemolysis may be present. Adult symptoms may include splenomegalia, jaundice, and gallstones. Thrombocytosis and thrombocythemia are conditions where an elevated platelet count is present in the blood. Generally, thrombocytosis or thrombocythemia refers to a secondary reactive thrombocytosis, which is caused by some other condition. When the underlying condition is documented, code also the condition in addition to D75.838. Hereditary alpha tryptocythemia is a genetic trait that can be associated with mast cell activation. This new code D89.44 is included with the subcategory for mast cell activation syndrome and related disorders. Code E75.244 is the new code added within the subcategory of Niemann-Pick disease. This particular form is known as acid sphingomyelinase deficiency type A/B and is rare and potentially life-threatening lysosomal storage disorder. ASMD type A is an early onset and acute neuropathic form of ASMD. Type B is usually diagnosed after 2 years of age. Type B has a slow progression. Type A/B includes patients with disease manifestations intermediate to type A and type B. These patients may develop neurologic symptoms during childhood and can have neurodegenerative and/or visceral manifestations. Next, there are indexed and tabular changes related to malnutrition deficiencies. And excludes 1 was changed to excludes 2 for code E63, while the index was revised for emaciation. Emaciation is now indexed to R64 unless specifically documented as being due to malnutrition. And there are changes for mental health. That depression is reclassified from major depression to unspecified depression with F32A. Intellectual disabilities, and one of the more common such genes related to intellectual disability is SYNGAP1. This is also frequently associated with other disorders including epilepsy and autism. SYNGAP1 related intellectual disability is expected to affect over 1 million individuals worldwide. The SYNGAP1 protein is critical to overall neurodevelopment. There is a code also note to capture other associated issues if documented. New guidelines were added, as we will see on the next slide, for substance-related conditions. Here are the medical conditions due to psychoactive substance use, abuse, and dependency. And the guideline is to follow the index for medical conditions due to the substance use, abuse, and dependency. As you can see, the example of alcohol-induced acute pancreatitis is coded to K85.2. And so also note it is important, do not assign F10.288 alcohol dependence with other alcohol-induced disorder per this guidance. The other guideline is related to blood alcohol level. A code from category Y90, evidence of alcohol involvement determined by blood alcohol level, may be assigned when this information is documented and the patient's provider has documented a condition classifiable to F10, alcohol-related disorders. The blood alcohol level does not need to be documented by the patient's provider in order for it to be coded. And now it is time for our first poll question. Flaccid myelitis is a rare but serious neurological condition. It affects the nervous system and is characterized by selective inflammation of the central gray matter of the spinal cord. Sudden arm or leg weakness, loss of muscle tone, and loss of reflexes are the most common symptoms. Neurologic symptoms may be preceded by a febrile respiratory illness and sometimes pain in the extremities. Severity of the disease can range from mild weakness in one limb to complete paralysis and inability to breathe. Cervicogenic headache is a type of headache resulting from referred pain perceived in the head from a source in the neck. A cervicogenic headache is a secondary headache resulting from disorders of the cervical spine and its components, bone, disc, and/or soft tissue elements. There is also a code, also note, for the underlying cause of headache if known. And then the index changes for inflammation is shown here on the slide. And of note, IMO requested the change on behalf of our customers. Looking at the popularity or advancement of treatment for CAR T-cell therapy for conditions of relapsed or refractory leukemia and large B-cell lymphoma, complications of the therapy have been observed. Two most common complications of cytokine release syndrome and immunoeffector cell-associated neurotoxicity syndrome, or ICANS. ICANS is defined as a disorder characterized by a pathologic process involving the central nervous system following any immune therapy that results in the activation or engagement of endogenous or infused T cells and/or other immune effector cells. Signs and symptoms can be progressive and may include aphasia, altered level of consciousness, impairment of cognitive skills, motor weakness, seizures, and cerebral edema. There is a formal consensus grading scale of ICANS grades. Providers will be able to describe the occurrence and severity of the complications with the various codes describing the different grades. The published paper information is posted in the reference section of the slides. Note the code first and code also text associated with the subcategory codes. And as G92 toxic encephalopathy became a subcategory due to the new ICAN codes, G92.8 and G92.9 were added to ensure other and unspecified toxic encephalopathies could be coded. Next, we will look at cardiovascular conditions. And as the science has advanced to refine and classify myocardial infarctions into various subtypes, a definition of non-ischemic myocardial injury has resulted from the advancement. Specifically, the introduction of high-sensitive troponin provides the ability to explicitly detect non-ischemic, non-traumatic related myocardial injury secondary to any number of conditions such as renal failure and heart failure. Clinicians need to distinguish whether patients have either a non-ischemic etiology of myocardial injury or one of the MI subtypes. Looking at the cardiovascular index reclassifications, the heart valve stenosis indexing was revised in situations where congenital conditions were the default code. IMO requested review of the stenosis heart valve as the indexing was inconsistent regarding whether it was assigned as congenital or stenosis. As you can see on the slide, the specific valves now direct one to see stenosis. IMO is seeking further clarification around indexing for the tricuspid valve as Q22.4 is listed after the C stenosis guidelines, but based upon other index changes following the C stenosis tricuspid to I07.4 is recommended unless congenital is documented in the records, and this is consistent with other heart valve reclassifications. Regarding this slide, I just wanted to highlight that this code has been effective since January 1st, and the frequently asked questions related to ICD-10-CM and PCS coding for COVID-19 were revised on August 25th of this year, 2021. And the resource slides contain a link to that documentation. So moving to the digestive system, the hyperplastic polyps of the esophagus and the esophagogastric junction region are characterized by hyperplastic epithelium with variable amounts of inflammation. The new codes capture esophageal polyps, and the code for the esophagogastric junction polyp was requested by the editorial advisory board for coding clinic. Looking at gastric cancers for the gastric intestinal metaplasia, the gastric cancer is the fourth most common cancer worldwide and second leading cause of cancer death. It affects approximately 26,000 Americans yearly, and gastric intestinal metaplasia is an important precursor lesion to gastric cancer. The location of gastric intestinal metaplasia is a significant predictor for gastric cancer risk and is one of the most important characteristics of the disease. The new codes identify gastric intestinal metaplasia with and without dysplasia. Once dysplasia is present, the location is less important as there is a higher risk regardless of location. In wrapping up the digestive system with index changes, you can see here that of note that allergic proctocolitis has been reclassified from K52 to K80.82 to K52.29. And on the next slide, we will review the skin and subcutaneous conditions. There are new codes for moisture-associated skin damage. The term moisture-associated skin damage delineates a spectrum of injuries characterized by the inflammation and erosion of the epidermis resulting from exposure to various sources of moisture and potential irritants. Moisture-associated skin damage is a complex condition which includes irritant contact dermatitis, which is persistent erythema with or without erosions of superficial skin layers. Irritant contact dermatitis has been shown to be a risk factor for full thickness pressure ulceration. Both urinary and fecal incontinence are known to cause irritant contact dermatitis on any portion of the skin. Similarly, skin around the stoma or fistula exposed to urinary, fecal, or fistula secretions is at risk for irritant contact dermatitis. Saliva or respiratory secretions from the mouth, nose, tracheostomy, or a spit fistula may cause irritant contact dermatitis on nearby skin. This slide shows the new codes for irritant contact dermatitis due to various sources, while on the next slide we will see codes related to the stoma and to the fistula. And so here you can see the codes and note the use additional code guidance to identify the artificial opening status. And now I would like to turn the presentation over to Teresa.
Thank you, June. I'm going to start with changes in the musculoskeletal chapter, and here at M31.1 we see a new code to specifically capture hematopoietic stem cell transplant associated thrombotic microangiopathy. Thrombotic microangiopathies are rare but life-threatening disorders that are complications of stem cell transplant. They can encompass microangiopathic hemolytic anemia, thrombocytopenia, and microthrombi, which in turn lead to an ischemic tissue injury. To accurately report HSCT thrombotic microangiopathy, you first will assign the appropriate complication as to whether it's related to a bone marrow transplant or a stem cell transplant. Then you would assign M3111, followed by the appropriate comorbid conditions that are existing in that patient, whether it's acute kidney failure, graft versus host, and so forth. To round out this expansion, M3119 was added for other thrombotic microangiopathy, and this is where TTP, thrombotic thrombocytopenic purpura, will be classified. We saw a title revision at M35.0. M35.0 historically was titled Sicca syndrome with Sjogren's in brackets, and that was a misleading title, and it appeared that the Sicca syndrome was intended to reflect the Sjogren's disease. Sicca syndrome was an alternate for Sjogren's, and that's an outdated title for Sjogren's disease. So it's favored to use the eponym Sjogren's syndrome. So Sjogren's is a systemic autoimmune disease that affects the entire body. Primarily, its most common symptoms are dry eyes and dry mouth. We have some new codes that I have here that have been added to this category of codes to identify when the patient has inflammatory arthritis, peripheral or central nervous system involvement, gastrointestinal involvement, vasculitis, or dental involvement. We also saw some new indexing related to faucet joint disease, which we were very happy to see. So those new index entries are over on the left-hand side, where we have new faucet joint arthritis, arthropathy, hypertrophy, and so forth. And all of those index entries direct to M47.819 for spondylosis, site unspecified, and within that category, you can then assign the appropriate vertebral level. Previously, this was a challenging condition to code because you kind of were directed to different types of spondylopathy through the index. If you tried to do vertebral arthritis, you ended up at spondylopathy inflammatory or degenerative joint disease of the spine. You could end up at dorsopathy or just spondylopathy. So this was a request that we made on behalf of our customers to the Coordination and Maintenance Committee because of the inconsistency and the difficulty in accurately classifying that disease. A couple of other reclassifications related to musculoskeletal system. Radiohumeral bursitis is now correctly located at M70.3 for other bursitis of elbow. And then primary osteoarthritis of multiple sites has been moved appropriately to M15.9, polyosteoarthritis unspecified. Non-radiographic axial spondyloarthritis is a type of axial spondyloarthritis. There's two types of it. You have the non-radiographic, and then we have ankylosing spondylitis. Non-radiographic axial spondyloarthritis patients do not have definitive X-ray evidence to identify structural changes in their sacroiliac joints, whereas ankylosing spondylitis, that structural change is seen on the X-ray. Patients with non-radiographic axial spondyloarthritis have chronic inflammatory arthritis that manifests with significant back pain, impairment in spinal mobility and physical function. This is a chronic progressive disorder that's worse at night and exacerbated after periods of immobility. You can see that both ankylosing spondylitis and non-radiographic axial spondyloarthritis are classified at M45, and you see we have new codes for all the various vertebral sites. Low back pain is another area where we had 3 new codes added. Primarily, it was that the expansion was done to capture vertebrogenic pain correlating with end plate changes at M5451. We also have codes for unspecified and other low back pain. In IMO's content, we have mapped terms specifically mechanical low back pain and postural low back pain to the other low back pain. I want to remind you that terms that specify acuity, such as acute low back pain, the indexing guidelines direct us to code the low back pain code M5450 unless we have something specified about the type of back pain. As acute, you assign the pain by site code, and then with chronic back pain, you would assign the appropriate back pain code and then add the code from G889 to pick up the chronicity. I thought you might like to see the indexing changes associated with the low back pain related terms. In the neonatal chapter, we see a brand new code at P0082 for newborn affected by positive maternal group B strep colonization. Group B strep testing is a routine part of prenatal care in women. Group B strep can be passed from the mother to baby during delivery, and Group B strep affects 1 in 2,000 babies in the US, and not all babies that test positive for Group B strep will become ill. But they wanted to be able to monitor those children with the code and see what was happening. So you'll note that this particular code has an inclusion term for contact with positive maternal Group B strep. This is an interesting placement within ICD-10-CM to capture contact with disease, as typically you might have expected that to be in Z05, observation of newborn for suspected disease, or perhaps Z20.818, contact with and suspected exposure to other bacterial disease. The green notes there highlight that you can use the P0082 with the other codes within P00 to capture when there's different kinds of infection. So our poll question here is going to work a little different because we inadvertently popped the wrong poll, but I'll walk through it with you. We have a newborn discharge summary where the baby is a singleton born vaginally to a 28-year-old mother. The mom's Group B strep positive and was treated prophylactically with antibiotics. The babe was delivered normally, and she was observed for signs of Group B strep infection during the stay. So the normal newborn is our discharge diagnosis, and then they also documented Group B positive mother without symptoms in the babe. So we aren't going to be able to pop the polling question, but I thought you could review the 4 answers and kind of think about in your mind what choices you would have. So Z3800 is the single live-born infant code. B is Z3800 with the P0082 for the newborn affected by maternal Group B strep colonization. C is just P0082 alone. And then Z30, and then D is Z3800 and Z05.1, when that Z05.1 is the observation of newborn for some suspected infectious condition ruled out. And the correct answer in this scenario is B for Z3800 and P0082, because the babe had contact with the positive maternal group B strep. So there is an index entry for contact positive maternal group B strep, which directs you to P0082, and we need to pick up Z3800 because this is a normal single vaginal delivery. Other codes added for abnormal findings in the neonatal screening. There's quite a few new codes. Many of these screening tests are mandated by state law. And as you can see, the codes identify a variety of abnormal findings related to metabolic conditions, endocrine, hematological, and other conditions like critical congenital heart disease. I did want to point out that P09.6 is for abnormal findings on neonatal screening for neonatal hearing loss. So if during the neonatal hearing screen, they have do not fail the test, you would also add P09.6. In the signs and symptoms chapter, we have extensive new codes to capture the acuity and the type of cough. Per the proposal, acute cough is one that is less than 3 weeks duration and typically seen in respiratory tract infections. Subacute cough is one that's 3 to 8 weeks duration. It is also seen in upper respiratory tract infections or various post-infectious coughs such as following pertussis. Chronic cough is a persistent cough over 8 weeks, and it really becomes a diagnosis of exclusion as it continues to persist after extensive medical investigation. And then we have another new code, R05.4 for cough syncope. And this code's to be used when the patient experiences a syncopal or fainting episode during or after a prolonged bout of coughing. And the documentation should clearly link the relationship. And you'll note the code first note to assign R55 for the syncope. I wanted you to be aware that there's no corresponding note at R55 to code also any associated cough syncope at R05.4. So if you have an ability to make a note in your encoder software, or if you're still using a book, you might want to. Other signs and symptoms codes, there was expansion to capture nocturnal polyuria at R3581. This is when the patient only has polyuria at night, which can be due to a fluid reabsorption or oxytocin issue. So the patient makes so much urine at night that they have to wake up multiple times to address it. And that's in absence of a neurogenic bladder, small bladder, or benign prostatic hypertrophy. We also have a new code at R7983, which is to specifically correctly capture homocystinemia. Previously, homocystinemia and homocystinuria were classified to E7211, which is a disorder of sulfur-bearing amino acid metabolism. But homocystinemia technically is when homocysteine is measured in the blood and found to be above a reference range. And so this is the appropriate classification for that. We also have new codes related to pediatric feeding disorder. So the R63.3 category was expanded. Pediatric feeding disorder can be described as impaired oral intake that's not age appropriate and is associated with medical, nutritional, feeding skill, and or psychosocial dysfunction. These kids might not be able to feed effectively, which leads to participation restrictions or modifications where there's mealtime interactions, whether at school, in childcare environments, or other, like a camp. Symptoms, pediatric feeding disorder can be classified into acute, which is less than 3 months duration, and chronic, which is over 3 months duration. Acute PFD can be triggered by medical conditions like esophagitis or choking, and chronic PFD has many causes, such as gastroesophageal reflux disease, dysphagia, malnutrition, or psychosocial issues. And I really wanted to point out the other two codes that were built into the classification to capture unspecified feeding difficulties and other feeding difficulties, like ICD-10-CM typically does. And you'll note that the associated indexing presents some challenges. Difficulty feeding is classified to R6330, which is the unspecified code, and problem feeding is classified to R6339, which is the other specified code. The team here at IMO really didn't think there was much difference between difficult feeding and problem feeding, and we did submit a letter to the Coordination and Maintenance Committee to reconsider the indexing between those two diagnoses. Another new code, R4588, for non-suicidal self-harm. This is the act of deliberately harming your own self through cutting, burning, banging or punching in objects, hitting your head. This type of self-injury is a harmful way to cope with emotional pain, intense anger, and frustration. This might bring a momentary sense of calm and release of tension. It usually is followed by return of those painful emotions. And although life-threatening injuries are not usually intended, with self-injury comes the possibility of more serious and even fatal self-aggressive actions. So if you have a patient that's admitted for non-suicidal self-harm, you would code this code plus the specific injury. Additional changes were made in the Z code chapter to specifically differentiate between personal history of suicidal behavior and the non-suicidal self-harm. In the injury chapter, we have new codes to specifically capture traumatic brain compression and with or without herniation. Brain compression and herniation occur when the brain tissue, the cerebral spinal fluid, and blood vessels are moved from their usual position inside the skull. And pressure resulting in that movement can be due to a traumatic head injury. And in this case, you would code the traumatic head injury from SO6 or the traumatic hemorrhages first, and then assign the code for the traumatic brain compression with or without the herniation from SO6A. But keep in mind that brain compression can happen from non-traumatic causes such as stroke, brain tumor, abscess, hydrocephaly, and so forth. And that non-traumatic brain herniation and compression is classified at existing code G93.5. We also had some expansion related to synthetic cannabinoids. At T40.7X, there used to be the code ranges for poisoning, adverse effect, and underdosing of cannabis derivatives, and they deleted those codes and backed them up to expand the category at 71 and 72 so we could actually capture the synthetic cannabinoids. Synthetic cannabinoids are those man-made psychoactive substances. They're called cannabinoids because they act on the same brain cell receptors as THC. And while two synthetic cannabinoids, dronabinol and nabilone, have been approved for use by the FDA for clinical use, there are other synthetic cannabinoids that are made illicitly. These codes do require the 7th characters to identify the encounter information, whether it's initial, subsequent, or sequela. Another COVID-related code that's new is U099 for post-COVID condition, and that's to be used to establish a relationship with the long-term effects following COVID infection, and that can include things such as loss of smell or taste or chronic respiratory failure. So we'd use this like you use sequela codes, you code the manifestation first, and then you would assign U099. I thought you might find the indexing changes related to this of interest to see that long haul COVID is listed and sequela of COVID is listed. There are some guideline changes specifically to multisystem inflammatory syndrome. If the patient has a history of a COVID infection rather than an active infection, you can code the multisystem inflammatory syndrome first, followed by U099. Additionally, the post-COVID condition describes that the symptoms or conditions following an active COVID infection should be assigned, followed by that U099. You would not use U099 for active infection of COVID. And that last paragraph is a caveat. If the patient has a COVID infection previously, still has some conditions lingering, and then develops a new COVID active infection, in that case, you can code both the U099 and the U071 for the active COVID infection on the same encounter. Social determinants of health have been another really hot topic in our society, and working to collect that information. I wanted to point out that there are quite a few existing codes in chapters Z55 to Z65. I've kind of tried to list them so you could see what was already in there if you aren't familiar with that area of the code book. New codes are in green, so we have Z55-5, less than a high school diploma. I would not use that code for somebody that is not an adult or post-high school age. Z58.6, inadequate drinking water supply. That particular category, Z58, was not included originally in ICD-10-CM. It is part of the ICD-10 World Health version, so this is the only code that lives there as Z58.6, so it looks kind of lonely. And then at Z59.0, those codes were expanded to capture whether the patient has sheltered homelessness or unsheltered homelessness. We also have code at Z59.4, which was expanded to identify food insecurity versus an inadequate lack of food. Other codes related to housing instability at Z59.81 identify whether that the patient's housed but has a risk of homelessness, or they have been homeless in the past 12 months. We also have codes at Z59.89, one code for the other. And I do want to point out that yesterday at the Coordination Maintenance Committee meeting, there was more proposals for additional social determinants of health codes. If you're interested in them and want to get them approved, feel free to go out to the CDC's website and comment. Those specific codes that were talked about yesterday, they're not currently in ICD, have to do with health, insurance, hardship, transportation, financial hardship, and material hardship. So there's a few codes out there. I wanted to go quickly over the official coding guideline. This is an old guideline, but they added that social determinants of health could be documented by clinicians and aren't the patient's provider, but they do have the ability to and the permission to document in the official medical record. This is a new guideline here that social determinants of health factors should be coded when they are documented. And here it kind of outlines what kind of clinicians may be documenting social determinants of health, but this is not an all-inclusive list. And then if a patient self-reports a social determinants of health factor, that documentation needs to be signed off on by the clinician or the provider and actually incorporated into the official medical record. Sometimes clinics or hospitals have a patient self-report screening tool to identify social needs that's integrated into the record. And this type of documentation allows the organization to track responses, make referrals to community resources, and perform follow-up. In the complications section, we have one code T80.82, which was related to the complications of immune effector cellular therapy or CAR T therapy. This complication is to be used with those codes that June referenced earlier for ICANS or the cytokine release syndrome. Additionally, we had codes added in Z9285 to capture when a patient has a history of CAR T cell therapy or other cellular therapy, and then other gene therapy. And I thought when I looked at these, I said, well, how would I know whether they got gene therapy or cellular therapy? And I found this website of approved cellular and gene therapy products by the FDA, and I thought it was pretty helpful because it outlines different products that might be useful to some of you that might encounter these types of therapies in your practice. Some other new codes that are miscellaneous. The one I wanted to highlight was Z7185 for encounter for immunization safety, where you shouldn't use this with Z7184 encounter for health counseling related to travel, as there is an excludes one note at Z7185. And additionally, they have a new guideline related to it. You should not use this code for provision of general information regarding the risks and potential side effects during a routine encounter for the administration of the vaccine. So if you are bringing your 6-month-old in for their shots, it was a planned visit, this code wouldn't be applicable. You just use Z23 for the encounter for the immunization. But if you are a patient seeking more information surrounding perhaps a COVID vaccine, whether it's right for you, whether you should do it, and want to talk to your physician specifically about that before making your decision, then this is a totally appropriate code. Z91014 is for allergy to red meat, such as beef, lamb, or pork. One other quick tabular change, you're now allowed the exclusion note change and the guidelines change, so you can code long-term use of insulin with a code for long-term use of an oral hypoglycemic. And just some other index reclassifications to look at on your own since we're getting short on time. And I want to turn it over now to Julie. Julie, are you ready?
I sure am. Thank you very much, Teresa. Yeah, now we're going to have a quick look at the changes that we'll be seeing to the ICD-10-CM calculator in the 2022 billing year. Just to orient you, the calculator is IMO's set of detail prompts that reflect ICD-10-CM details. You know, so if you're our customer, you will see these prompts. You might call them modifiers, you might call them qualifiers. Our intent is to guide clinicians to the most specific code possible for their patient to bridge that gap that can sometimes happen between the documentation of clinical care and successful coding for billing. Okay, so this year there were only 8 starting points of our calculator that were affected by ICD-10-CM changes. Here's a list of them. I'm going to go through them in alphabetical order. Anemia, it's actually a pretty big set of detailed prompts. This depiction here is just a small part of it. So here's the pyruvate kinase deficiency, and then there's the other glycolytic enzyme. They split that out. For contact dermatitis, those new body fluid and stoma related additions are there. There are quite a few new values, as you can see. So all of those details are captured here. Headache, there's our cervicogenic addition. Niemann-Pick disease, type AB is there. It's a distinct entity, sort of intermediate between type A and type B. For pneumonia, there's our new COVID virus pneumonia. I'd like to point out that once you select due to COVID-19 virus, no further details will be selectable in the pneumonia calculator. On to poisoning by psychotropic drug, there's our new synthetic cannabinoid value for selection. Secondary malignant neoplasm, so that is neoplasm that has metastasized to one of these locations. Ovary is the only site that got a new bilateral code, but in that calculator, there are other body sites that are lateralizable. So we went ahead and added the bilateral choice for those. Those ones will map to 2 codes, one for right and one for left. And then SICA is our last entry. As you can see, there are those new additions for the Sjogren organ or body system involvement that have been added to that group of choices. Okay, that is the extent of our calculator changes. So this slide shows our references, and I will hand it back over to Jordan. Thank you.
Awesome, thank you, Julie. All right, at this time, we'll be kicking off our live Q&A. So if you had any questions coming into the webinar or questions you have now, please enter them and we'll begin answering them live. I just want to note that as we start receiving your questions, just excuse any brief silence for our team to review and answer.
Hi, this is June, and we received a question with regards to around alcohol use disorders. When the question is, can you advise on when you should use an ICD-10 code or when you would use a DSM code? And it's a great question, and there are codes that the APA through the DSM-5 recommends be associated with their terms and their descriptors. I would actually, as far as which code is actually being reported, would check with your local state requirements, because I know various states have different reporting requirements around the DSM-5 recommended code along those lines. However, the ICD-10-CM and the Coordination and Maintenance Committee and the APA have been working to align the codes and the terminologies so that there is not a disconnect between the terminology and the codes. So those codes should be similar. However, again, I know there's various reporting requirements, and I would recommend checking within your own organization and your state about those reporting requirements.
We had a question for someone wanted to see the Niemann-Pick slide again, so here it is. While we can keep working on the questions. So the next question is for the COVID vaccine counseling. Can we bill Z7185 as the primary ICD-10-CM code? Does anything else need to be billed with it? I think that you can bill that code standalone, as the purpose of the encounter is for counseling. And you would only code anything else if there is another condition documented within the record that's active that you're treating as you normally would. And then there's another code about, do you code insulin use with diabetes type 1? And I believe there's a guide, there's a, in the code book, I think it says there you don't code it because it's inherent. I'm trying
yes, I believe you're correct.
I'm looking at the book.
Yep, all cases of type 1 should be treated with insulin, so
Shouldn't quote
it's
it.
not necessary to report that
Yep.
separately.
And there's also a question along the same lines about both insulin and oral anti-diabetic drugs can be used together. And yes, that is a change if the condition warrants that. And clinically, and Dr. Glasgow, you may have some additional thoughts, is there's times when the patients who are type 2 and need an additional help with the control versus the oral. So I believe that was the rationale for that change.
That is absolutely correct. A patient can be on both. So they changed their guidance to allow both of those codes to reside on one patient. Yep.
June, did you see that there's a note to address the new depression code?
Yes, so the depression was reclassified from to F32.8, and it states now on A, sorry, yes, 32.A from the F32.9, and the code actually states the depression is unspecified versus the index guiding to a major depression.
And then there's a question regarding specificity. Does that mean providers choosing non-specific diagnosis codes would have the claims come back?
There are certain select group of codes, I believe this is related to the Medicare code editor, that one of the two remarks need to be entered, and those remarks are either the information was not clinically available, or was not available, or it was not clinically determined. And because there are instances, depending upon the site or the location and the treating provider, that it may not be always of the information be determined. So one of the two remarks needs to be entered if one of the diagnosis codes is selected. Otherwise, the claim would be returned to the provider for those remarks, one of the two remarks.
There's another question on the depression code. Is F32A and HCC? I don't know that the updated HCC list has come out yet.
Right. This is part of the, yes, it takes a little time from when the new codes are active. They're evaluated through the process to determine if the new codes are eligible for an HCC designation. And that time frame, while it does vary, I believe it's usually later in the fall, around November, when a file is posted for CMS with their determinations around HCC indicators.
Dr. Glasgow, would you like to address the calculator question regarding major depressive disorder?
Sure. The calculator for major depressive disorder does prompt for the severity, but the severity only applies to the current episode. So if you don't have the episode information supplied, then there isn't a code for severity. In other words, the severity doesn't apply to the overall diagnosis of major depressive disorder. It only applies to the current episode.
We have another question. Is a complication code assigned when the patient has a breast implant associated anaplastic large cell lymphoma? And I don't know if you saw that, the guide, you are not to report a complication code with that. You would only report the C84.ZA with an additional code to identify whether the implant is still present or it has been removed.
Yeah, we received a question around the uncontrolled diabetes and the indexing. And yes, that we have submitted a request. We are continuing to follow up. And of note, yesterday during the Coordination and Maintenance Committee, there were some addenda changes to similar types. And so it was raised again as a comment around the consistency for those. So we do realize this issue and continue to work for resolution around this.
And the slide deck will be shared following the webinar for those of you that are interested. Jordan, I think, has a few other additional closing comments. Jordan, do you want to wrap it up?
I think that's a great idea. All right, so we're going to go ahead and close out for today, and we hope you found the information in today's webinar useful. Be on the lookout for the recording of the webinar and the slide deck and a certificate of attendance. If you have any information or if you want any information regarding IMO or any of our solutions, please contact your IMO client executive. Again, the recording will be made available later this week. And thank you for attending, and please stay safe out there.